Hello friends, this is Sudharshan, and in this episode we'll talk about Eyelids chapter part 2, where we will see Hordeolum, Ptosis and Symplepharon. So coming to Hordeolum, two types, internum, externum. Externum or internum is called as stye, and this is a acute suppurative meibomian gland inflammation caused by the Staphylococcus aureus. And here we see two stages importantly, cellulitis and abscess because of the staphylococcus. So painful boils will be seen in the eye, and because of which swelling and intense pain will happen. Foreign body sensation symptoms like photophobia, irritation, itching, lacrimation will be seen. So treatment is the medical management with antibiotics, analgesics and steroids, and epilation of the lash along with hot compress can be done. Then ptosis. So ptosis will be the drooping of the eyelid because of the levator palpebrae superioris or the Mueller's muscle. So there are two types of ptosis, congenital and acquired. So under congenital we have the simple superior rectus weakness, blepharophimosis syndrome and synkinetic ptosis. So in the simple ptosis it's mostly a neural crest cell failure that happens. It can be uni or bilateral. Here the most common reason will be the Mueller's muscle function will be reduced. Then there can be superior rectus weakness, blepharophimosis syndrome as I said. So this will be along with telecanthus, distance between the canthi, and then epicanthus inversus where the superior canthus will be inverted. Then synkinetic ptosis. As the name suggests, there is a misdirected movement. So here the V3, mandibular branch of the trigeminal nerve, or in this there is a small nerve called nerve to lateral pterygoid that is misdirected to the Mueller's muscle, and this is the important reason. That is why there is a compensatory chin elevation that will be seen. Yeah, and this also we see in the pinhole vision as well. So synkinetic ptosis, also called as Marcus gun winking syndrome. And in acquired ptosis there are four types: neurogenic, myogenic, aponeurotic and mechanical ptosis. So in the neurogenic ptosis we have the most common causes: third nerve palsy, Horner syndrome and multiple sclerosis. Myogenic, various myopathies we can think of, like neuromuscular disorders, any muscular trauma, myotonic dystrophies. Aponeurotic we can have because of operation, there can be dehiscence of the aponeurosis, or it can be involutional as well. Mechanical will be lid tumors. So diagnosis can be done using the history and physical examination. So in the history we ask about age, mode, duration of onset, family history, past history, history of trauma, and whatever the factors in the classification we have listed, those factors. Then on physical examination, first we have amount of ptosis, that is unilateral or bilateral. Unilateral will be the vertical height of the palpebral fissures. Bilateral will be the corneal cover measurement. Ranges from mild to severe, that is 2 to 4 mm. Then marginal reflex distance, MRD1 and 2. In MRD1 there will be the patient and examiner at same level. The examiner will put a torchlight and examine the degree of ptosis in the patient. Whereas in MRD2, so in MRD2 that is the calculation for reverse ptosis that happens. So in this we measure unilateral or bilateral retraction. So in unilateral it will be MRD2 of the normal and abnormal lids, the difference. Then for the bilateral, 5.5 minus MRD2 of the either lids. And for palpebral fissure, MRD1 and 2. And then coming to Berg's method or levator function. In this we keep a small ruler in the eyelids and ask the patient to look up, and we measure the distance between the eyelids and the eyeball. So the grading in this case, normally it is greater than 15 mm, like what we see in the Schirmer test. Good will be around 12 to 14 mm, 5 to 11 mm will be fair, less than 4 or 5 mm will be very poor. And there are some other tests like Tensilon and Schirmer test, which are very obsolete now. And treatment will be the surgical management irrespective of the congenital or acquired. So in the case of congenital, we should do the surgery at the earliest possible so that amblyopia won't happen. As we told in amblyopia, that ptosis is one of the important reasons there. And some of the common surgeries, just the names: frontalis sling and levator resection. The goal is same, levator palpebrae superioris. For good function, levator resection. For bad function, frontalis sling. Then Iverbush or skin approach, and Blaskowicz or conjunctival approach. Then last but not the least, symblepharon. So symblepharon is a condition where conjunctival adhesions will be seen mostly because of any infective condition of the eye. Like it could be a trachoma, it could be a conjunctivitis, could be a corneal ulcer, bacterial corneal ulcer. Top 3, these are the important reasons. So because of the adhesions, we have the photophobia, irritation, itching, lacrimation, disturbance in vision. It will be a disfigurement. So it doesn't look good when you have any pus or any kind of infection visible in the eye. And because of the adhesions, the lid movements will be restricted. So because of which the eyelids cannot close properly. The eyelids will become heavy because of the pus and inflammation. So that is why exposure keratitis will happen. And because of which conjunctivitis and corneal ulcer will set up. And here the treatment will be symblepharectomy to remove the symblepharon, or using a sweeping glass rod twice a day along with a Fornis, ring or contact lens. The same thing we do even if there is a foreign body in the eye as well. So that is with the part 2. So thank you so much. We will see in the next lesson.